tell them that I'm
Okay.
about to tell them Dr. Muñoz is my favorite. So I don't think we should be recording that.
No, I want that in a recording.
Well, it's already recording, so there you go.
Yeah, so today you meet someone that will show that is the he was sitting where you are a couple of years ago, but I'm going to let him tell you about this. So he started his career very early to decide he wanted to be a physician scientist, and somewhere along the line he was sure that that's what he wanted to do. So he applied to the MD PhD program. Dr. Munoz applied, and what when he did his PhD, he finished his PhD very fast. He will tell you all of this. But he got 7 first author paper on his CV. And if you look at ResearchGate, he has some of the highest cited papers in glioblastoma. But today he's about to take a job as a specialist in maternal-fetal medicine. And I think he will be a good example to tell you that he did work in glioblastoma, but he's now doing maternal fetal medicine. And so what you will see, he will explain to you, is how the different research intersect. So no matter what research, you might be sitting today and thinking, I'm doing cancer research, but maybe I want to go into OBGYN. How is that going to fit? So you will see an example today how research, it all melt into each other. And so when you do one research, you learn to do hypothesis-driven research, you do all these publications, it helps you to whatever it is you want to do. And he has stuck. And today, ask him question, how was he able, with the different obstacle in the science, how was he able to stick with it and still continue? And ask all your questions today. Today you get, and I think you're starting out. You heard two already established physician scientists. But I think today you will be more relatable to Dr. Munoz because not so long ago, he's still young. Not so long ago, he was sitting exactly where you're sitting. And find out what made him stick with it. And how can you follow and stick with it? So Jesse, I'm going to go back to the students committee now, but I'm going to be listening to what you said.
Thank you for that, Dr. Rameshwar. Let me see how we share this. Where's my share option? Do I not have a share option?
There should be the green button on the bottom for share screen.
As if I haven't been doing this for a year now. There you go. Awesome. Is that good, Lauren?
Perfect.
Awesome. Well, it's great to talk to you guys today. Like Dr. Rameshwar said, yeah, not very many years ago, I was literally in that same field. And by not very many years ago, I mean like I graduated from NJMS in 2015. So within the last 5 to 6 years. And I am currently in University of Texas within the Maternal-Fetal Medicine division. And so I have the privilege to talk to you today about translational medicine, which is a hard goal really to talk about because there's so much that goes into it. But ultimately, I want you to think about it like, is it a concept or is it an obtainable goal? And I think everyone's definition of translational medicine is very different, and that's fine. You just have to think about the approaches that we take to get there. And then can we actually make it a real goal? So the question with translational medicine is that on the left hand, you have the theory or the preclinical work, or the basic science work, if you will. And on the right hand, we have the clinical practice. And I'm very fortunate to be on both sides of this. But ultimately, in current society, in our current medicine, what we really have is a loss in translation. So how do we necessarily go from the left side of this screen, which is the theoretical side, to the practice side on the right side? And we'll talk about a couple different approaches. But again, the overall concept of what is translational medicine, what does it mean to different people? And like I said, this is a very difficult topic to talk on. And I promise I try not to take the entire hour, but I did try to cover many other aspects of this approach. And, what does it look like? I'll briefly talk about how do you fund this? Like now I'm in the midst of like funding research, and how does that actually happen? I would have appreciated if somebody had spoken to me to this about many years ago, because I didn't fully understand the process until actually recently, and how that has shaped my career. And even just, as Dr. Rameshwar mentioned, I'm on the brink of accepting an academic job right now. But that was part of my negotiation, the grant funding. And so we'll talk about that, how that actually works. And then at the end, like I said, I wasn't there very long ago. So at the very end, I did put 4 important points for you to optimize your summer. And what are things that you can do this summer that can definitely impact your career many years down the road? So this is my quote unquote conventional path. And so my conventional path, I started at the University of Puerto Rico with my bachelor's degree. That took 4 years. Then I moved on to NJMS, GSBS, the MD PhD program. As Dr. Rameshwar mentioned, it was a fairly quick process. I started in 2009, transitioned to the lab in 2011, graduated from, so started like June to July of 2011, defended my thesis April of 2013, so about 20 months later, and then finished my last 2 clinical years and graduated in 2015. So in total, about 6 years or so. And overall, it was a great experience. There's so many opportunities at NJMS and GSBS. I did graduate with about 22 publications, if I was not mistaken, from that 6-year period. So it was a very productive experience, my 6 years at Rutgers, and obviously, did change the way things went down the road. Subsequently, during my training, and we'll talk about how I switched a bit, but ultimately, my PhD was within stem cell biology with Dr. Rameshwar, but also I had continued a certification in neuroscience as well. And getting from neuroscience to OBGYN is a very different road. And I think it talks a lot about the clinical practice of medicine. While I enjoyed the neuroscience and the research behind it, the clinical practice of neuroscience was definitely not for me. I explored both neurology, which was very conceptual, but not very hands-on, and then neurosurgery, which was the opposite. It was very hands-on and not necessarily very conceptual. And neither one of those were very fulfilling to me. And so luckily, that was my first rotation of my 3rd year of med school, my quote unquote 3rd year. It was really my 5th year. And from there on out, I just kept a completely open mind and ultimately formed a really close relationship with the maternal-fetal medicine specialist at NJMS. And that's how I chose my career. So it was more about mentorship and guidance than actually the science behind it. And so then I went on to OBGYN residency at the Cleveland Clinic, which is the #2 hospital in the country, and they'll never let you forget it. There's signs literally on every street corner. And it was a great surgical experience. There was not as much basic science research, and I'll talk about that in a little bit, and you'll see how it's just different when you're a surgical trainee. But ultimately, it was overall solid clinical and surgical experience, and that ends on another 4 years. So we're now 14 years down the road. And then after there, I went on to subspecialize in high-risk OB and maternal-fetal medicine, similar to as like my mentors from years prior, as they were my role models, essentially. And while I was at it, I also obtained an MPH for academic reasons, to be honest. While as a resident, I became quite representative in advocacy in women's health and contraceptive care, and ultimately decided to pursue an MPH for those purposes. That was a total of 3 more years. And then I can't say where just yet. Dr. Rameshwar knows the answer to this, but I was just accepting a staff attending position. And we'll talk about that transition as well as I go through it in the next coming months. But this is more or less the conventional pathway for an MD PhD, a little more abbreviated if you go one way or the other, but about the same pathway. And we'll talk about the impact of this pathway versus others. But as I mentioned, I was a summer intern too. I've definitely been there before. And the reason why I wanted to show this is because I was at 3 different institutions in 2006, 7, and 8. And I had gone to NC State my first year, and we worked on mouse brain gonadotropes. And that was, I think, one of the last times I worked with mice. Over at NJMS, I worked with Dr. Rameshwar actually in neural differentiation. And then my summer after that, I had gone to HMS, and we looked at voltage channels in the fetal mouse brain. So all quite neuro-related, which is where I thought I was headed. And, life will give you different pathways, and you just take and learn from each one. So each one of these experiences definitely provided me with a set of tools. And when I get to the final 4 points of things that you learn from your summer rotation, that's what you should learn. You should learn how to take tools. Ultimately, if you're working with Drosophila, or if you're working in cancer biology, Alzheimer's research. It's really the translatable skills that are going to make a difference later in your life, not necessarily whether you study this folding protein and this specific part of the kidney in a cow model. It really, what it's going to come down to is what were the skills that you learned, and can you translate those skills? If you learned it in the cow kidney, can you move it to the mouse lung? And could you move it to the human placenta, for example? And that's really what's going to make the biggest difference when it comes to career development, your translatable and your sellability, basically. Can you sell somebody on your skills? So what does translational medicine even really mean, right? Like that was my goal today, to talk about translational medicine, and whether, like I said, it was with a goal or just a concept. And this has many, many different definitions, but I felt that this one from the European Society specifically for Translational Medicine was a pretty good one. And it's an interdisciplinary branch of a biomedical field, and it's meant to support three main pillars. And that's probably the way I liked it the most, because it talks about the benchside, the bedside, and the community at large. And so these are the three things that translational medicine tries to effectively bring together, to go from the microscope, the blood sample, and the mouse to the practitioners, the people who are at bedside with the patient. But this should not be a one-way road. It should go in both directions. And I think that's where our job here lies. When you're focusing in translational medicine, can you create this two-way road? I was recently in a lecture by one of the big editors of a journal who said that there was a study that showed 89% of clinical research, or research that's actually performed, never sees the light of day. And actually it's mostly because of failures in the experimental design, the analysis, or the lack of translation. So while you could apply a large amount of alcohol and kill every lung cell in a culture, can you translate that to a human being? The answer is no. So a lot of the research lacks this translatability, despite the effort and the focus that we put on translational medicine. And so I implore you to think about these three pillars when you're trying to come up with projects. And this applies in every direction. So if you're on the lab side and you're investigating a molecule, for example, that inhibits some sort of receptor in lung cancer, is there plausibility for that in humans? Can we get it into humans? If you're talking about small molecule RNA therapy, is there a way to deliver it in humans? That often causes the biggest problem. While we can do many, many things in the lab, can we move it towards the patients? And then it goes in the opposite directions. Do you have the patients for it? Do you physically have enough patients with type 1 diabetes to make this feasible? Or is this an orphan disease where there's not very many patients who have this disease? You have to think of the overall impact that the research will have, but it has to go in both directions. A common issue that I ran into not that long ago was there was a lot of studies looking at statins, and they looked at inflammation and infection. And so they tried to apply this to obstetric infections. The problem with that is that statins are category X in pregnancy. So what does that mean? That means many, many years of research that were put into understanding the mechanisms as to which statins can form and be an anti-inflammatory for infection can't be translated, because nobody will actually give it to a pregnant human, given that it's category X. It would go against the medical society's applications of medicine. That doesn't mean that it wasn't funded for 20 years of research and that there's a lot of understanding of it. It just means it's not going to move to obstetrics. And so that's why the three pillars sort of have to be together. And you have to think about them as a concept, not individually, but really how this is a two-way road. So this is my two-way road. And I always hated when research would talk about their specific research. So I'm trying not to do that, but this is my concept of what translational medicine is. Currently right now I work in obstetrics and high risk obstetrics. So my patients are all pregnant. And my current research is looking at RNA diagnoses as a biomarker. Biomarker research is very translatable, right? It goes directly from the patient on the left-hand side here, without going through all the details, but essentially RNA isolation, did a number of arrays, actually worked with Lauren, who did a lot of the informatics work for me. And that just also shows having a good relationship with people you've worked with before, right? I trust Lauren, I've worked with Lauren before, and absolutely, of course, she did the work for me. And so I appreciate the work that Lauren did, but we worked together half across the country. And then, there's two roads from the informatics that Lauren did. Number one was prospectively. So that's me in the clinic collecting, consenting patients, collecting specimens, and using it as diagnostic criteria. But also the bottom arrow, looking at, taking what I know now about the biomarker and the peripheral of the patient and take it back to her disease process. And I specifically work with invasive placental disorders, but by better understanding, some of the work that Lauren did with me in the informatics and the RNA studies, I now bring it back to the patients and I look at their placentas and look at the study the different protein processes. And that continues to feed forward, because now if we know the pathways that are involved, we can continue to talk about now small molecule inhibitors. And now you're talking about biomarker development, but also small molecule inhibitors and pharmacological inhibition. So this is definitely the translational medicine approach. And this is the approach I take. And I think this is my definition of translational medicine. But this is also it. We have to think about going from the patient, the approach, and ultimately your goal. What is your goal, right? In obstetrics, my goal is obviously happy, healthy baby and mom. For those who are interested in the historical perspective, this was the first infant delivered by uterine transplant. And I'm a lefty, so that's me on the left. And so that took a lot of translational research, and everything happened much before we ever got to the first transplant. And then clinically, we got her through her pregnancy, which is quite complicated, and ultimately to the delivery of the first baby on the right. So this is also a definition of translational medicine, looking at the patient, the approach, and the goal, and how do you go from one to the next? Identifying the clinical problem, tons of research that went into it preclinically, and then how we translate it into the real goal, which of course, like I said, for us is always the cute little healthy baby. So why do we need translational medicine? Well, first off, it allows for a cost-effective means of healthcare development. So this is how we do things. If we know that it can be translated from one direction to the other, it cuts out a lot of the development and it moves things along much faster. And I have really good examples of how translational medicine really did move things along the way. And I'll show you those in a couple of minutes. It also shortens the duration of trials. If you have a number of preclinical models and you know what to expect, many of those phase 1 and phase 2 trials can be shortened if you know what's coming. And I think a lot of that was seen with the COVID trials. Why they were so short was because we knew what was coming. And so we can close the gap between what we know and see in the clinic, what we know and see, but also what we practice and do. Like, do we do the right thing? I don't necessarily know. We're always well-intentioned, but we don't really know if we don't study it. The big thing you always hear is the bridging the bench to bedside gap, how you can go from the research perspective to the clinical side. And that's what translational medicine obviously aims to do. And lastly, there's a novel application of new technology. So, there's new things always being developed on the research side. And how do we bring that over to the clinical side? It has to begin with translational research and the lab research first before we can bring it into a patient. The aims ultimately are going to be therapeutics, the development of medical devices, tools for diagnosis, and this is where I throw in the biomarkers, and lastly, avenues for community engagement. How do you bring together the physicians, the patients, and the researchers so we all talk the same language? And there's significant numbers of research where we identify the wrong control groups, for example, and a ton of studies are done where you have the wrong control groups and not translatable, or the final answers that you get weren't really helpful because you had the wrong approach to begin with. So how do you get the community all in the same language? That is easier said than done, I promise you. And so this is kind of sad, but it takes about 17 years for only about 14% of scientific discoveries to actually make it to the clinical practice. And I think, that's a very long time for a very small number of any scientific discoveries. And, translational medicine is trying to shorten that, but also, of course, keep patient safety in mind. And so if we look at healthcare in this model, starting from the upper right, which I know is kind of weird, but this is how it came. You start with like the molecular level and you work your way all the way up to the organ level. And then lastly, your clinical indicators. And then it sort of enters this larger cycle of the discovery side. Shortly after that, you work through the early steps, clinical trials. And then these are some large hurdles. And we'll talk about the hardest hurdle in the clinical trials. Then you move on to your clinical guidelines, your measurements, your outcomes, and then enters the additional field of personalized healthcare, which sort of circles back to the molecular level. And how does that impact patient care? Maybe the small molecule inhibitor you found for breast cancer is better served in the African-American population or in a triple negative subset. So this is where we talk about personalized healthcare. And that's also a big part of translational medicine, how it fits into the overall big picture of both research and healthcare. So here's an example. If we use the HPV vaccination as an example, HPV was first considered possibly part of cervical cancer in the early 1970s. But by the time it slowly made its way over to what we call Gardasil or cervix or Gardasil 9, that didn't happen until just a couple of years ago. To be very honest, it was the original Gardasil only had 2 genotypes and then finally moved on to the quadrivalent, which we currently have in 2014. So overall, that process took just shy of 50 years. So that's a very long investment to understand the process. And don't get me wrong, Gardasil is extremely effective, but this is how long it took to get there. But another example is if we use PD-L1 inhibitors or PD-1 inhibitors, you can see that, when we really started looking at PD-L1 in cancer was in 1992 or so is when it was actually cloned. But by 15 years later, about 25 years later, we had FDA-approved medications. So comparing this to the HPV vaccine, this was done in about half the time. And so this would be the shortening of duration from optimal translational medicine approach. And one could sarcastically say that HPV is predominantly a women's condition, and perhaps that's why it took longer versus a urothelial carcinoma, which is more male. But regardless of how you put it, it took half the time to develop the PD-L1 inhibitors and get them through approval than it did for Gardasil. So the translational medicine is seen as a continuum. So ultimately from the left side, you have your basic scientific discovery. So you identify that promising gene. You can look at some basic epidemiological findings, and then you slowly move over to early translation, the late translation, which has the clinical trial later phases. And then there's this hard part here of dissemination and adoption. And dissemination and adoption, you think wouldn't be the hardest part, but it truly is when you can actually convince community providers to do things, to act on what you have shown before, and then ultimately the adoption. And in public health, we talk about dissemination, early adoption, late adoption. It's a quite complex process. But as I mentioned earlier, while there were multiple studies on statins and infection, when you get to the dissemination and adoption, nobody in my field is going to disseminate or adopt statins in pregnancy, given that we know it's a category X medication. So that research gets halted right during the early translation phases. If we look at translational models, there's a traditional approach, which is you go from the physiochemical to the biology. You look at your in vitro to in vivo, which is in animals. Then you move through your phases, right? You use your phase 1, which is going to go from animals to humans for a safety analysis on a small group, usually with single doses. And then you move on to your phase 2, which will have multiple doses, or perhaps a larger group. And then your phase 3, which is you're using healthy volunteers, actually. And then you're going to move on to patients, and these are patients with the condition. So I'm not sure how interactive the group is, but what do you think the hardest part of this entire process is? Any takers?
Does anyone over here want to gather a guess, especially after our discussions with the people from Janssen last week? We have someone saying phase 3.
It's actually phase
Stage 1.
Moving from animals to humans. Again, a lot of this has to do with the adoption process. If you have a process that cannot be translated over to humans, it doesn't matter what you found in the animal, but also how homologous is the animal and the human. Are we talking about zebrafish to human? Are we talking primate to human? It's very different, the animal you're comparing, and you're assuming that the processes are homologous. And so this is actually the single hardest part between patient recruitment, physician recruitment, but also the pathophysiology. Does it translate well? Oftentimes, this is where we find the problem. And sometimes, if you think about like animals, they're often bred to be genetically all the same. Humans are not. And so sometimes what you find in animal models or in cell culture, which are also uniform, don't necessarily transfer over to humans. So this is why phase 1 is considered the single hardest part and where most interventions will actually fail. Moving from phase 2 to 3 is actually quite easy. So looking at translational models, there's a 2-phase model. So there's you start again with the basic science research, you translate it over to human studies, and there's a number of blocks along this way. when you're moving to the second part, which is the clinical knowledge and adoption to improve overall health. And so there are significant translational blocks. These include the lack of willing participants. What are you asking from these patients? And what kind of condition do they have? Is it something subtle or is it something life or death? You know, if we're talking about refractory ovarian cancer, the patients may be more willing to a compassionate treatment. But if we're talking about something much more subtle, then there may be a lack of willingness from the participants. Also, what are you asking them for? Are you asking them for a shot? Or are you asking them for a daily infusion for the next 25 days? That will definitely change the approach. And so that's a continual block. There's regulatory burden, as I mentioned earlier, why statins never made it through pregnancies, because it's already category X. And then there's many other problems. There's practice limitations, there's fragmented care. There's databases that don't talk to each other. And the big one here is also a lack of funding and a lack of qualified investigators. And I'll try to address that later to give you guys just a basic more knowledge of what does this entail and how can we overcome this? And the question is, have we overcome it? It's a really good question. There's a 3-phase model where you start with your basic biomedical sciences, move on to the clinical efficacy. This will require this T1 here, this time phase 1, in efficacy research, which is considered a translational type of research. Then from your clinical efficacy and knowledge, you have to move on to the effectiveness. Like, is this going to be effective in patients? Is it going to improve what we currently have, right? So that's more outcomes research. And it's also overall comparative effectiveness research. Like, if you found a treatment for cervical cancer that heals or cures 80% of patients, but we already have one that cures 90% of patients, is it really going to be effective? The answer to that is going to obviously be no. And then as we move on to our last translational phase, you have to, how do you deliver this reliably and in all settings, right? I think this was what the early COVID vaccines found, right? Like, can you deliver a -80 requiring vaccine to rural Texas? The answer is no. I see some patients that are 7.5 hours away from me. There's no way I can get a frozen -80 vaccination to those patients. And so those are some limitations that we find as well. And you have to take these all in consideration, because I remember when the COVID vaccine came out, that was the first thing I asked. I was like, why would they create a vaccine that requires a -80? While as other companies found one that didn't. And so that was a question that probably should have been asked when they were first developing it, not when they're trying to like mass ship it to every part of the country. And then there's the NIH roadmap, which is a very interesting approach. So the NIH roadmap takes, again, these 3 pillars of the bench, the bedside, and the overall clinical practice. And they start funding initially the basic science research. And then they have that translational phase 1, which involves the early phase 1 and phase 2 trials, which I mentioned, where most studies will stop. But that would be the translation to humans. And then once you're on the bedside, the translational research doesn't stop, it continues. This is where you work on human clinical research, you have controlled observational studies, and those phase 3, and even after those, a phase 4, which is large population-based studies. That's sort of where we are right now with the COVID vaccine. And then the translational approach to the practice, how can you deliver this to the right patient at the right time? Sort of like personalized medicine. And how do you identify any gaps in care? And from that T2, they even broke it further down to look at systematic analyses and systematic reviews. Like, are we doing the right thing to the large studies? And that's where the clinical 3 and 4 come in, especially, and the survey research, that just makes more reference to if you got your COVID vaccine, for example, you registered for the vaccination system where they track a lot of the outcomes as well. The CTSA is an interesting approach. It's an approach from NIH, and the Clinical and Translational Science Award Program. The reason why I threw this in here is for things for you to identify in your career. So this is an early pilot research program where the NIH funds an increasing number of institutions. I guess now they're up to like 60 as of last year. And they've allotted a large amount of money to these institutions. And these are institutional grants for pilot programs. So if you're interested in translational medicine, it requires minimal preliminary data. And they fund, in general, it's about a year at a time. I think it is renewable, and it's about $50,000 a year for your research, which can make a huge difference. And I only know all of that because I literally just submitted a letter of intent yesterday for the next cycle. But ultimately, how does one really fund all of this? Where does the money come from? How does it come? And this is a concept I didn't understand until recently. And so when we look at the R grants from the NIH, that's sort of like what you always hear about. You always hear about the R01, which is a 3 to 5 year grant. It's the most commonly used mechanism for funding research. But this is very specific. It supports discrete, specified, and very circumscribed research projects. But I never really heard about everything else. So an R03 is a small grant program. It's non-renewable. It's for 2 years, and it's mostly meant for your pilot and feasibility studies. So once you have the initial biomedical approach, then you can move on with a pilot or feasibility study. And then an R21 is an exploratory grant. This is quite interesting because this is all new research. It's a 2-year grant. It actually requires no prelim data. So it's sort of like just a concept and an exploration of what you think might work, and usually never requires prelim data, although they say it's helpful to have some. And that's really all I knew. I knew sort of about the R01, kind of heard about an R21, and that's where I was. But more importantly, to a trainee, actually, are the K Awards. So the K Awards, there's many of them, but I highlighted 4 of them here, and I separated them on purpose. The KOA and the K12. The KOA is a Mentored Clinical Scientist Research Development Award, and the K12 is a Clinical Scientist Institutional Career Development Award. So while it sounds the same, they're actually quite different. The KOA is specifically you as an applicant apply to, so you can be at any institution. You apply for a KOA award. It lasts up to 3 years, if I'm not mistaken, but it provides salary benefits as well as research benefits. So this applies for both. And this is NIH's way of supporting translational medicine if they can support your salary and you don't have to worry about it, but also support your research. The K-12 is an institutional award. So this one, if you are looking for an institution to join, the K-12 is through the institution specific to departments. And I can tell you the ones in obstetrics, what they are, but it really changes by department and by institution. And so it's very similar. It actually mirrors the KOAs. So 3-year award covers your salary. The difference is it's given to the institution. So if you're looking for a job and you're interested in clinical research or you're interested in translational research, finding an institution that has a K-12 is quite nice because that can buffer you while you apply for any other awards, since that is given by the institution to you. What I'm trying to say is you don't necessarily have to work as hard for a K-12. You definitely have to work quite hard for a K-08. But there are benefits and downsides to each one. The K-01 is a workforce diversity grant. It's mostly meant for postdocs who are entering the workforce. The K-99 is also meant for postdocs, but it is a early researcher to R01 or R00 independence program. So that's why I put them a little separate. But in the graphs that I have coming up, they show up. So I just wanted to see that they do exist. I don't think they apply to anyone in this group, and they don't apply to me either just yet. So when they look at evaluation of K award successes, they're looking at the program participants. So overall, do we have equivalent gender, races, and degrees, and the time that the person took from their degree to the award, and have they had prior NIH support? These are things that go into the program, right? And ultimately, which programs are being used the most, what awards are being given, and then what are their outcomes? They're looking at how many papers you publish, what are your citations, what was the overall impact factor? More importantly, did you go on to get other awards? The point of a K award, they call them the kangaroo awards because they're meant to leap you from your early career as you move on, right? So did you move on to get funding? What employment sector did you join? Did you go from an adjunct faculty to an assistant professor? Did you move on to professor? What was your rank and progression? And then again, how long did it take you to get an R01? I know in our field, K08 awardees and K12 awardees, about 80% of them do go on to receive an R01 shortly after. So that just talks to the success of these K awards. And just another tool to think about when you're looking for your career and where you're going to go. You want somewhere that can support your ambitions. So looking at KOA award success overall, unfortunately, this trend is from 15 years ago. I couldn't find one any closer than that. That was the most recent NIH report. I think it's because they do them every 10 years, and this was the 2011 report. But overall, what I want to talk to you is about the overall award success. It's actually quite good. So I know people talk about the doom and gloom of grant funding and, oh, the funding rate is 3% or something. This actually shows quite good funding rates, and this, I can tell you from personal experience that 15 years later, it's about the same. So if we look at funded KOH, which is the darker blue bar, and unfunded KOHs, while there's still more unfunded than there are funded, overall percent-wise, about 40 to 50% of KOH submissions are being funded. And that is definitely much higher than any other institutional grant or any other R grant, which can be up to the single digits. If I'm not mistaken, the neuroscience NIH division is something like 8% when it comes to R awards. But when we're talking about 40 to 50% for K awards, it's actually quite large. And so that's why the award rate is so high. But also who's applying, right? So this also talks about who's applying, which I think is a very interesting concept. And this is sort of where I was telling you the other K awards show up. And why the KO1 is largely PhD candidates, and that's because it's a workforce diversity into research funding, and that's just not applicable right now. But focusing on the middle bar, which is the KO8 awards, these are mostly clinicians, which is actually quite interesting. These very few PhD candidates applying to an individual KO8 award, and the overall majority are going to be either MD clinicians or MD PhD clinicians who are also in translational research. And the other degree applies to other like veterinary degrees and other degrees. But the overwhelming majority, something about 80-something%, are going to be either an MD or a combination of an MD PhD. So this is our pool, and the pool, like I mentioned from the prior, is funded at about 40 to 50%. So this is a huge resource that exists. If we look at the early career training awards, again, the overall K awards for career development, these graphs, a little more recent, go up to 2012, look at the individual funding by degree type. And so the majority here are going to be still the PhD candidates, but overall the MD PhDs overall are going to be the fewest number because they're the fewest trained. Even though they represent like 1/5 of the PhD candidates, and then the MDs are somewhere about 1/3. So I think, to me, I found this very shocking, just the number of straight up MDs who are applying for NIH grants and getting funded. And then if you look at the institutional career development awards, it's quite similar. It's very similar trends, but it has more to do overall with the absolute number of people applying. And here the difference between the PhDs and the MDs is actually not as large anymore. It's literally down to 80 people. And this was almost 10 years ago. If you look at the R1 awards, these have interesting trends. So if you look at the, and I think I may have, I actually did include it. So I did include all three. There was just like large graphs, so I had to break it up. If you look at the MD awards, an MD with prior research experience obviously is going to have the greatest overall success, and that applies to the PhDs as well. And I'll spoiler alert here, but so do the PhDs. If you have prior experience in funding, of course, you have the highest success rate. Then following them is the MDs without experience, which is like that dark bar, which is about 14%. And then it's about the same for the MD PhD, about 14%. Looking at the PhDs, it's slightly lower. It's like 12.5, but actually not that big. So the point of this was to show that the overall degree that you have really doesn't make a huge difference. It's almost in the single digits, if not decimals, differences between who's being funded, which, was not the trend when I thought about it about 5 or 6 years ago. I was like, oh no, I have to have X degree to do better funding. It's about the same, no matter what you do. Which was an interesting concept. So the NIH approach, they've created this roadmap initiative for which the three things I've talked about sort of fall into now, which was the R awards, the K awards, and the CTSA awards. And so the CTSA, which I mentioned earlier, this now funds about 60 institutions, but back in 2012 funded only 55 institutions. And this represented a large amount of the funds that come to the NIH. And actually, 10 years ago, it was the largest program at the NIH. And if I'm not mistaken, it actually still is the largest program at the NIH. So identifying these centers when you're early development for your clinical and translational research is fundamental and makes a huge advantage as to what options you have moving forward. Since these, again, are institutional and not necessarily individual. You're only competing for the funds within your institution. So how do you maximize your summer? And this is sort of the last part I have for you. And I stole this picture of Lauren off the website, but I think she's the only person. Oh, I guess I recognize Nikki in the photo. So how do you maximize your summer? Number one, be involved in literally every aspect. Try to think about the research, solutions, what alternatives exist, what are the pitfalls, what are the potential pitfalls? Could you see this being a problem down the road? And is it translatable? Always keep that in mind. You can cure cancer in a petri dish, but if it's not translatable, if it's using 100% ethanol, I promise you it's not going to be translatable, and that'll be the end of it. It'll fall along that other 89% of research doesn't make it out. And then, how does one submit a manuscript? That's one of the biggest skills, no matter what you choose. I think in clinical research, it's very significant because once you become a clinician, nobody's going to teach you this. I promise you, not as a resident, not as a fellow, nobody's going to actually teach you how do you write and submit a manuscript. How do you write a cover letter? I still write cover letters exactly the same way Dr. Rameshwar taught me 10 years ago. I actually use the same exact template. This is your opportunity to learn, appreciate your mentors, and see what you can learn much more than just the lab. Same thing applies to a response letter. There is like an anatomy to a response letter. You can't sarcastically respond like, no, I don't like the way you reviewed my paper, or obviously you didn't read my paper. Like there's an anatomy to it. And same thing, I still write my response letters the same exact way Dr. Rameshwar taught me back in 2009. And then a letter of intent for research support. Literally, I just messaged Dr. Rameshwar 2 weeks ago, and I was just like, how do I write a letter of intent? So creating a stable mentorship is key, but also being involved in learning each and every aspect beyond, can you pipette something? How do you run a Western blot? Those are all great, but really what you need to learn is the logistics of everything. And you can definitely learn that on this summer. What does a paper look like? How do you use references? You'd be surprised many times when I talk to my colleagues and I was like, oh yeah, no, I use EndNote for all of my references. I've used it since I was a grad student, and they don't know what EndNote is. So definitely try to learn as much as you can on all aspects of research. Second, create those relationships. Many students and trainees will come and go from a lab. I promise you, we had more trainees than I could ever count or remember. But there are some that I know created a relationship with that I still talk to on a daily basis. And, their successes are our successes. And so we want to work with you. But this may be harder for the shyer people, but definitely creating those relationships. Because if I didn't have a relationship with Lauren, how could I have gotten anything done when I needed help and I didn't have the manner to do it here? It's because I have a relationship with her. Also remember that medicine and research is a really small world. Everybody knows everybody. You will review each other's papers. You will be in each other's study groups. You want to create those stable relationships because you don't know who's going to be evaluating your work. Even if it's your paper, who's going to evaluate your paper? If it comes across my desk and I recognize the name, maybe slightly different than if I didn't. And you never know who will need your help. Obviously, you're all here for a summer experience. At some point, you'll probably need a letter of recommendation, but you'll need more than that. Like I mentioned, 12 years later, I messaged Dr. Rameshwar and I was like, how do I write a letter of intent? Can you help me? If I didn't have a relationship with her, she could have easily have just said, well, it got lost in my spam and never responded, for example. But instead, she actually called me on the phone and walked me through the whole thing. So you definitely want to create those relationships because you never know what you need. Like I said, it's a very small world. Use research as a tool. Who here remembers what my PhD was in? What research did I do and what was my residency and fellowship in? Completely different things, right? PhD was in neuroscience and stem cell biology. Absolutely nothing to do with my residency in obstetrics. Also had nothing to do with my fellowship in high-risk OB. Definitely not related in any way, shape, and form until you look at it this way, which this was one of the first figures of my PhD thesis, in which we looked at exosomes and we used a nanocyte for size quantification. And then literally a month ago, very similar, right? same Western blot, looking for almost the same markers and exactly nanoseries. Like it's literally the same thing. And that's only because, and on the left side, we were working on glioblastoma brain tumors. And on the right, I'm looking at invasive placental disorders. So I couldn't think of a more different model. But ultimately, it's the skills that you learned that you can translate. And if tomorrow you told me I had to work on, tumor of the kidney, I could do the same exact thing on tumor of the kidney and get funded. So I think, while you may be working on a very narrow and specific area, learning those skills and translating them actually makes the biggest difference. So I'd focus less exactly on what the topic is and what are the skills that you can get out of your summer rotation. Then, learning how to read papers, learn how to read articles, learn how to read them critically. There's what they call the 4 C's of Journal Club. There's purposes for collegiality, just meeting your colleagues and talking about things together, which is socially, it's great, but it really doesn't by itself doesn't achieve the goal. There's also a content and criticism analysis of what are you actually reading, and the 4th used to be cost and no longer applies. The 4th C meant by doing journal clubs, if I had access to one journal and Lauren didn't, but Lauren had access to another journal, we would get together and discuss your respective journals. And that way I would cut the cost out of having to purchase another journal. But I think now with more universal access and access to libraries and electronic access, that's really not a problem anymore, but that would have been the 4th C. And then as a trainee, if you decide, to pursue a clinical route, I actually asked Lauren, I'm like, I don't really know what the crowd is. Am I talking to medical students? Am I talking to graduate students, undergraduate students? And I basically got that it was a smorgasbord. So I think as a trainee, if you decide to pursue a clinical approach, clinical training and residency is difficult. And doesn't really lend itself to spending multiple hours in a research lab. And so that's where you have to be creative and you have to look at retrospective clinical research and take the other translational approach, right? Like when we talked about models of translational medicine, translational research, there was that T1, which was how do you go from the lab towards the patients? But then there was that, T2 and T3 looking at, how effective is it? What other approaches do? What are the outcomes? That is also translational research. And you can definitely do that even during your clinical training. You can still identify mentors at different levels. I have research mentors, I have clinical mentors, I have surgical mentors, I have public health mentors. You can never have a shortage of mentors, but always make sure that your mentors are also invested in you, right? It should be a two-way road. And so not everybody can be your mentor, but it's nice to have a couple to choose from. And then I would also say identify any access that you have to data sets, because those make life very easy, especially if you come back to that first point where you're trying to create the retrospective clinical research. If you know that your department has access to multiple large-scale clinical trials that could be secondary analyses, and those are easy presentations and papers that you'll be surprised that nobody actually looks at. But that's also translational research. It doesn't always have to be one mold, if you will, which is why I was trying to show 3 or 4 different approaches to translational medicine. And then I included this as a future resource for you. I think it's all a very great resource. They have a number of videos, I obviously can't click on it here, but they have like the issues in translation. They go through the different approaches of drug discovery. It's directly through the NIH. So I leave that there for you to use as a resource. They have the video series. It's actually very educational and it really does walk you through a lot. And that is it. I guess I'm 10 minutes early. And I always use the same baby with the eviction notice on my end slide. So that's why I left the baby there.
No, it's good you finish early, because I'm sure they're going to have a lot of questions. Jesse, I was just wondering, is it possible for you to send a bio sketch? I want to share with the student, because I want them to see the amount of publication you have and how you try your best during your busy schedule to prevent that gap in your CV. That's very important for them to prevent that gap, which you did effectively, preventing that gap.
Well, because I was job hunting, I can tell you that I have a CV on my desktop.
Okay, so Lauren, can you send it to share with?
I can just actually share it right here.
Okay, that's a good idea.
That should show up, right?
Mm-hmm.
Yeah. So you're talking about the gap.
The gap. You did a very good job, even during residency, to prevent that gap in publication.
Right. So when did I graduate? about here.
Mhm.
Because I graduated in 2015. So this was sort of like the end for
By
me.
the way, today, Jesse, today impact factor came out for cancer letter is over 8.
Oh, wow.
Yeah.
But then, still I kept in contact with the lab. And so that led to additional authorships just by keeping in contact. Like Nikki and I, just talked the other day. And then, as I mentioned, like, as you move along, knowing what data sets you have at your institution allow for you to continue to produce things even during a clinical time.
So you said something very key for them to know. You kept in touch with Nikki as of recently. Nikki and Jesse were in the lab together. So they didn't just go their separate way. That's how you develop network. You develop network from the time you're in this program, you have developed network. And those networks are the ones that will help you as you go forward in your career. Because Nikki is now a faculty at University of Maryland. Jesse will be a faculty somewhere, and they still keep, even though they're in different field, they keep in touch. Because this is a very difficult field, and most people, they keep their network going, and so they have a network now.
Yeah, and through that, friends of Nikki become friends of mine. And so that makes a big difference. And
yeah, exactly.
I'm pretty sure Nikki told you that we were submitting a paper
Yeah.
together.
Yeah, and so I'm the one who was the editor. I don't know if she told you of that section series. Right. So I'm the one. So that's another thing. Because I'm heading that series, I put Nikki onto that, and then Nikki put now Jesse. So that's how it's gonna go. These people who are you doing the program with, they're gonna be in network. They may be in different subspecialty, but they're gonna be in network.
Yeah, you remember Vivian? Vivian graduated not that long ago.
Yeah, I saw that on LinkedIn. Yes. Yes. So so Vivian was in the program from Puerto Rico, and Jesse mentored her. She got publication. She went on to do a PhD, and she graduates with strong PhD.
Mhm.
Do you guys have any questions you want to ask?
I can't imagine they wouldn't have questions.
I
We
see.
have a question. Want to come ask?
Do,
Were you raising your hand or was that just stretching?
Jesse, you have like about, at one point, you have about 80 people.
The Premier, can you talk about the research
Mhm.
prior to applying to the MDP? Okay, so I do have a question from Rebecca that said she's an undergraduate, part of the NJMS NERA. Can you talk about the research experience prior to applying to the MDP sugar and what helped me decide to go into medicine rather than a PhD only? So that was an interesting thing. I had initially planned to pursue a PhD in neuroscience, and that had been my plan all of undergrad. And it was actually in 2006, I had applied to the program at NGMS and had accepted, had flights, everything booked. And then it fell through. I lost my mentor. And so he was down the hallway from somebody else and asked her if
I was just a student, I was on the committee.
even if she already had students, could she adopt me? And that person was Dr. Rameshwar. And she was the one who was like, you should, don't limit yourself. Think about the potential that you can do if you were to pursue translational research as an MD PhD instead. And so the following year, I ended up at Harvard Medical School based off that advice. And I worked with an MD PhD. He was in cardiovascular, again, completely different. It was in cardiovascular medicine, but seeing that he could see patients and he had amazing lab work, like I was like, I want to be you. So I think a lot of it had to do with mentorship. It completely had to do with mentorship. Had Dr. Rameshwar not told me you should consider this, and had I not seen a model MD PhD, I know I would have not gone down that road. So I think the biggest thing is mentorship.
Before you came here, Diego was telling them the same thing: mentorship. And those mentors you got to see, do that person care about you, what happened to you 10, 15, 20 years from now? Those are the people, and you will know when you meet them, you will know.
And mentors will make a big difference. How did I end up choosing maternal-fetal medicine? I ended up choosing it because I created a relationship with the physicians that we had at NJMS, and they became my mentors and advisors. Had I not had that relationship with them, I may have not pursued this road. Actually, I know I wouldn't have, because I had looked at pediatric surgery before that. So
Jesse, the NERA program run through Dr. Soto Green office. There's a lot of students in this program now, which is the NIHR 25. I don't know if Lauren told you. They were fed into medical school and now fed into this program. So the NERA program is really good. And Umberto runs a NERA program. I think Umberto is here, isn't he?
Yes, he wrote Mentorship Matters.
Yeah.
I also had another question. Can you clarify or explain what you were
There he is.
filling?
I'm introducing you because when you put that, I was so glad you put a community. I saw when you talk about translation, because I think it's so important for the students to know about the community link.
Absolutely. That's definitely that third pillar that's equally as important. You know, we saw that with like hesitancy for the vaccination, right? Like the community had a big impact. And how many studies have been done on, you know, hesitancy of vaccination? I feel like in pregnancy, there's at least a study a month on like hesitancy. You know what is a crucial thing I'm finding out? So there's so many cultures in the community where the word cancer is so tabooed, and it really impacts their treatment because they don't talk and impact. And I think community engagement will become so important. Oh, absolutely. I had a 35-year-old friend of mine who just passed away from non-small cell. It was Danish, and they don't speak of the word cancer. So you get treatment. Yeah, I'm from Guyana. I'm from a culture where cancer is tabooed. And so the family don't know there was cancer in the thing. They don't go for their treatment. I mean, it's terrible. So that's a field that community engagement is really needed. So there's a question in the chat that said, can you clarify or explain what you were referring to filling the gap in your CV? So I think maybe the word choice was wrong, but really what we're talking about is once you begin your research career, not creating a gap. So, you know, it's easy for you to get overwhelmed one year if it's your intern year of clinical training or your first year of staff, that you're getting set up for things that you create what they call a gap in your CV. So you had published papers in 2008, 9, 10, 11, 15. Suddenly in 2016, 17, 18, you did not. And so you created this gap is what we were talking about. So not necessarily a gap year, like I took a year to go to Uganda, or I took a year to study additional research. The gap that we were talking about in the CV is that research gap that it's like we can't fully explain what happened for 3, 2, 1 years that sort of creates this weird gap. And so like when they're looking at overall funding of research, they want to look at your productivity, but also your consistency. Like, did you continue research every year and then you dropped off the radar for 5 years and then came back? And that's fine, but why did it happen? Did it happen because you had personal issues? Was it because you pursued a personal hobby of some sort? But it's notice is what Dr. Ramesher was trying to say. So she was trying to say that even despite clinical training that I did for the last 7 years, you know, still continued to be involved, to continue to perform research and still reach out to the communities without creating a gap. That's what I meant by like gap. I know Shakti is going to give the keynote speaker when he comes. It's the same link. You should link in, because Shakti was, while he was doing residency, he was always emailing me. I got to make sure I don't have a gap, because it's just when people look at your CV, even when you're looking for jobs, it really is like a green light. It's like when you apply to medical school, if you have a C in your transcript, everyone notices. It's the same thing. Yeah, totally. But not to say that C's are the end of the world. I will admit on this recording that after my, like, I think it was my freshman year or my second year, I had 4 C's on my transcript, and Dr. Ramesher was like, you cannot do that. But it, you know, at the end of the day, it all works out fine. Things happen for a reason. And then, Lisa, you know, when I want to introduce him, I wanted to say something. So if you look at his CV, which he just shared, it looked like, wow, the easy thing for people to say he's a high achiever, but you know what he is the work ethics. If you think you're bright and you don't need to do anything else, you're in for a rude awakening. Work ethics is very important. No, I totally agree. You don't have to be the smartest person in the room to be successful. You just have to work hard at it. And the people make a mistake. They think, oh, I'm smart. I went to this school and that school. I don't have to try. No, doors don't open for you. It's you make your own career. Somebody asked if they could have my contact info or email. Absolutely. I think Lauren has my office number, my email. It's all in my signature block. So you can feel free to take it from there.
And we have,
Lauren, you will share, right?
yes, I'm gonna put it in the
Because,
chat.
because Jesse, I think some of them may stay in contact with you, even when they're applying for residency, they may ask you questions and things like
Here,
that.
I'll just put it in there right now because I'm taking it off my email block. Which
Because the truth is, Jesse, a lot of them are sitting where you were at one point. It seems, Lauren, someone want to ask a question.
Yes.
Hi, Dr. Muñoz. Thank you for coming. I just have a question. You put out a stat that it takes 14 years for about
You
14%.
want to introduce yourself so everyone else know which program?
Oh, yes, I'm sorry. My name is Jacinto, medical student, MS2. You put out a stat that it took 14 years for like 15% of the.
about 20 years for 14%.
Yes, exactly. What do you, I just want to pick your brain, and what do you recommend for it to be condensed down and making it shorter as opposed to just taking too long in 20 years, you know?
Yeah, so like what I had mentioned before was that they had talked almost 90% of research fails. It never makes it to the translational phases. You can make that much shorter by identifying all of what you anticipate to be your pitfalls ahead of time. Do you have your proper control groups? Are you looking at the right study group? You know, are we chasing this molecule for breast cancer only to find out that it only helps a very small subset? Because then what that means is that if you take that molecule to a large clinical trial, it may very well be negative. There are a number of molecules that have gone to clinical trials and overall been negative. But then when you look at a specific subgroup and you're like, well, actually, if you're HER2 positive overexpressing, it completely wipes your cancer out. But now you're behind the 8 ball, right? You've already spent the last 8 years trying to develop something which was negative, and then once you have a negative clinical trial, it's very difficult to move forward with something because you have large scale data to saying what you're looking at is negative. But if you done the translational approach early on, identifying the personalized medicine approach, the specific subgroups, looking at the right models, you could have avoided all of that. And that's how you shorten things down. And the best example is everyone's like, oh, this COVID vaccine was made so quickly, it must not be safe. It was the opposite. It was made very detailed. It was very specific, and it looked at one particular part. And so that's how you get this like shortening of things. It also probably helps that companies shut down production of every other drug they were doing except for the vaccine. But still, the timeline of them developing it was so fast because it was so personalized and so targeted.
So Jesse, they had a nice trip to Janssen, which is one of Johnson & Johnson company, and the students asked that question about the vaccine, and what they were saying, when America shut down in the time zone, another one of their company in another part of the world, so the research was continual. That's how that vaccine was not haphazardly produced, actually.
No, it was very targeted, and I think
yes. So just to follow up on that question, some of it also is luck. For example, you know, Jose Basilga just died. Well, Jose Basilga was a fellow at Sloan MSK, and Genentech came with a HER2 antibody. And at the time, no one believed antibody will ever work. So they said, oh, I have this foreign fellow. You know, we don't want to waste the American fellow time, just give him. It turned out that built his career and he became very famous because it did work. So it's just being lucky. So there's an element of luck also.
Thank you.
no problem. And also, there's also the impact of disease prevalence, you know, is something that's in breast cancer more likely to move along? Absolutely. Versus something, you know, like vulvar cancer, which has like 1,000 cases a year. So the overall clinical impact versus, you know, breast cancer, that's 1 in 8, is going to be significantly faster in breast cancer than anything else.
You know, and also just a general curiosity. You know, I was at there's a journal club of extracellular vesicle that people from all over the world. So every now and then I logged in, and there was someone from Brazil this morning talking about Chagas disease and how the exosome release are spreading Chagas disease. That's part of the spreading because all the, and then I'm thinking, okay, I just emailed this carbon filtration company, said, you know, you might want to get those people in the Brazil to do a clinical trial. So it's just something you may see, oh, why am I interested in this? But if you actually have a curiosity, a curious mind, you will actually enjoy this.
But also talking about timing, it's interesting you mentioned Chagas disease. One of the junior fellows here, she was doing research on Chagas disease and like screening patients, and in a year of screening, we had 0 cases. So, us here doing a translational Chagas disease project would not be fruitful.
No, you have to go to South America, Brazil. So why did they screen here? Because they have a lot of migration from South America?
Correct. Yeah, the CDC recommends if it's from an at-risk zone, then the patient should be screened. A lot of our patients here are from the south, like south of the border. And so they landed at high-risk population.
And not even one positive.
Well, we had false positives, but then like once you have the positive, you have to send it to the CDC, and all the ones that we sent them have come back negative.
But Brazil have a lot.
No, we have none, which is, again, a translational medicine approach. Like, would you want to study Chagas disease here in Texas? It
No,
would not be very fruitful.
well, they don't know that, but that negative results is positive results, because even I thought, I wonder if they're bringing it there. So even that is important. They should publish it, actually.
Yeah, it's
Even
been
though
0.
it's one of those rare cases where negative results could be important.
Yeah, if you want to study C-sections, we have lots of those. If you want to study obesity in the South, it's prominent. But do you want to study obesity in Portland, Oregon? Probably not.
Do we have any other questions? Okay, Dr. Muñoz, thank you very much for your time.
Oh, he's not going, because he has to speak
know.
to Eli.
I was going to say, yes, I think you already know from email that Dr. Rameshwar is asking you to speak with one of the students. So I'm going to ask that everyone else signs off and has a wonderful evening. Next week's flyer will be out early next week, but same place, same time.
Lauren, let them unmute and give Jessie a clap.
Yes, if everyone wants to give a round of applause. So I will remove all the people who aren't removing themselves.
Oh, you can remove people?
Yeah.
Oh,
Muting people is my favorite hobby.
deleting people.
It says, are you sure that you want to expel them?
Before Umberto go, don't delete Umberto.
Okay, I won't.
Where is Ellie? Is he here?
Yeah, he's here.
I don't see
Yes,
his
I am
name.
here.
Oh, yeah, here he is.
Like the
Umberto, I want to formally introduce you to Jessie. Umberto does a lot of community programs. So I think, where's Umberto? Umberto, you should try to contact Jessie and keep in touch with him. You're muted, Umberto.
Yes, I will. It was a great presentation, and I like the relationship and the way that you put the MD to the research and how you went back and forth. I think that it gave our students a way to understand and personalize what research looks like. Because we always think of people in research and white coats in labs and doing all this other stuff, but these presentations allow us to see how research is personalized and why it matters to some people and the purpose of it as well.
Lauren, you have a lot of students you have to delete out.
I think she's getting there.
Jessie did a good job, because I was half listening to the student exam.
Thank you. It's a tough topic.
No, there are 2 students that I had the same exam for the same lab, Carlos lab. I wanted to fail both, but I didn't.
You can't say that on the recording.
Wait, Lauren, you still recording?
We can end the recording already.
Yeah, Lauren, you should delete out, go backward. And delete.
Situational awareness.
Okay. Lauren, I think eventually you have to delete yourself when you finish. Okay, well, Jessie did a good job. I'm gonna have to leave you now.
All right,
because
nice to meet
you have the one-to-one meeting now.
Yeah, I met with my director. I'm going to take that job I emailed you about.
I discussed with Sarah Morelli. She thought was the best place to go, because she know that lady you met, think she was introduced. That program is amazing. It's a good place to start your career and go as a chair somewhere else after a couple of years. I think that's how it has to go.
Yeah, we met today about it. I'm going to take it.
I think so. As soon as I see it, I did my own thing, the environment. is there to make you succeed, which I like a lot. And I
Well,
think
it's nice to see
that,
you.
so next year when you come back to speak to the same students, you'll tell them why you choose that thing. And I think I know why and why it's worked for you.
And how it works your first year.
Yeah, you're going to, I'm not worried about you, Jesse. Trust me. You're not the one I
I
worry
did
about.
submit that letter of intent for the CTSA award.
Yes, yes, yes.
I submitted it yesterday.
Okay, Umberto, now we gotta get Ellie a job now.
Lauren is still recording.
Okay, Lauren is still recording. Lauren, why are you recording? But Lauren is gone.
No, she's
No, she's
playing around in the background.
Yeah.
But I think Lauren is logged in, but she's not there.
Sorry, I just turned the volume back on. I was just saying goodbye to the students here and talking about the specific games. Can you hear me?
Yeah.
But Lauren, you want to log out to get rid of those students?
I got rid of them. I got rid of them. The only people here are the people who you see on the screen. We have,
Yeah, but it's still recording, Lauren.
oh yes, I have to get rid of that, don't I? Sorry. Okay, stop recording.